might see something you don't see on your deck, okay? All right, here we go. So, start very, very simple, okay? So, we're going to talk about the individual male and female reproductive systems, and then laced in there, we're going to talk about what happens during and after fertilization. We're not going to go into fetal development or anything like that. We're in anatomy and physiology. We're not in pediatrics or women's health, so this is going to stop essentially after fertilization and implantation. We're going to take it to there and stop there. Okay, so we're not going to talk about any fetal development or stuff like that. But just to understand some of the terminology, like we always do, gonads mean reference to sexual organs that produce actual gametes. So ovaries and testicles, testes, all right? Ducts, the duct work in the male reproductive system is fairly extensive. Spermatic ducts approximate 600 meters long if you lay them all out together. So there is a long way. Now, not each individual one, like the entirety of them would be about that long. We're going to talk about accessory sex organs, like you've probably heard of Cowper's gland or the bulbourethral gland, things like that, that also help facilitate implantation, because all of this is ultimately directed at, physiologically speaking, fertilizing an egg. Okay, and so bulbourethral gland, Cowper's gland, things like that produce essential nutrients and fluids and ejaculate that facilitate that sperm being motile and alive until it reaches an egg. Okay, and then of course supporting structures. As far as this is not a comprehensive list. Gynecology, obstetrics, you used to see OBGYN together. A lot of clinics are now calling themselves women's health clinics. Our course is called women's health instead of OB-GYN now. You'll also see urology. Now, urology a lot of times is the milieu of male sexual reproduction. So if you have, issues with male sex organs, penis, testes, scrotum, things like that, you can send that person to a urologist. But there also is a subset of urogynecology that specifically works with female urological disorders, which of course there are. All right, and then andrology. Andrology is the legitimate face of what low T centers and synergenics purport to be. All right, so andrology is very closely, intricately related with endocrinology, you can probably imagine. It deals with disorders of testosterone production and so on and so forth. So sex hormone production and replenishment for that patient. It is a actual endocrinologist with subspecialty training or urologist with subspecialty training, vice somebody like me who got a job at Synergenics and now gets paid to just dole out testosterone shots. Okay, you know what I mean? Okay. Synergenics, low T center, right? Synergenics, okay, so you probably heard me reference Synergenics before. They're local here. They got started in San Antonio. The CEO and the CFO are actually iPad grads. And now most of the people, if you go into Synergenics, are IPAC alumnus, all right? And they actually bought Low T Center, so they're doing pretty well. So they're riding the wave. Medicine quality, I'll just leave that to myself, but you may be able to interpret or intuit what I think about it. Anyway, so start with the male reproductive system because it's easier, frankly. It's like, it's like working on a Jeep. Everything's outside. It's right there. It's easy to get to. You know what I mean? All right. So, testes, epididymis, we're talking about the ducts, okay? The accessory system, this is what I was talking about. And we will see these in the lab as well. We have some decent specimens. Guys, I want to tell you something. We have a dick jar. Okay? Yeah. We got a jar, we got a glass jar with specimens in it. Okay, we do, we just do, all right? So, all right? So, we also have a vagina jar. Okay, so we have a jar, all right? But we have some decent specimens in there where you can really see some of these accessory sex organs. Because honestly, the seminal vesicles they have a very, very, very important role. Like I said, just based on the ejaculate that comes from testes and the prostate, have a decent amount of sugar, glucose, fructose, what that thing needs to survive the journey, literally, right? Seminal vesicles provide it with a significant more amount, significantly more of it that they need in order to make it there, or else fertilization would not be nearly as successful, nearly as often. All right. Bulbourethral glands. Has anybody ever heard it called Cowper's gland before? Some in your previous training, that's the same thing. And then of course the prostate. Not only does it cause problems when it encroaches upon our urethra, it actually produces prostatic fluid that contains zinc, that contains other antibacterial nutrients, I guess, or substances that then do facilitate the passage through the remainder of the urethra. Because don't forget, when the urethra is not passing ejaculate, it's passing urine. And urine has stuff in it that is noxious, that is toxic, that is maybe potentially bacterial. And then it has to make its way through the vaginal cavity as well into the fallopian tube. So it needs to have equipment for the journey. And this is what these accessory sex organs do, okay? In the scrotum, everybody understands, I think at this point, the main point of the scrotum. It is to keep the testes outside of the body cavity because spermatogenesis needs to occur at a temperature lower than 98.7 degrees Fahrenheit, all right? So we have the testes outside the body in the structure to keep that temperature relatively lower. And then there are structures like the cremaster muscle and the dardos muscle that can bring them closer or farther away depending on the external temperature and the body temperature as well. So if you have like something like cryptorchidism, you guys know what cryptorchidism is? If an undescended testicle, is that a more familiar term? An undescended testicle, cryptorchidism, right? The real danger of a cryptorchid testicle is that it's not properly developing. Right? It's developing inside a warm cavity in the body, right? In the pelvic cavity where it's not supposed to be. So those seminiferous tubules, all of that ductwork that I was talking about might not form correctly. Also, what's not happening is spermatogenesis. In this case, pre-spermatogenesis is not necessarily happening correctly either. So it can be a very high risk for infertility, and it can also be a high risk for your patient for testicular cancer. It's a higher risk for testicular cancer. So that's just a caveat of what the scrotum does. So if you're ever out there, you're doing a well child or a well baby visit, annotating and actually palpating for dissension of the testicles is crucial, right? Crucial, right? So anyway, scrotum. It's weird to just say it like that and just not say anything afterwards. All right, it is, again, it's skin, it's multi-layers, it's not just skin, it doesn't have a fat layer. Why do you think it doesn't have a fat layer? Insulation, right? It doesn't need insulation, that's why it's there. Okay, that's why it's there, exactly. So it has very thin layers of fascia. The dardos muscle itself, which is what actually brings the scrotum up and gives it that wrinkly, shrunken appearance when it's cold, is a very thin layer of skeletal muscle. It's a very thin muscle. They have fascial tissue there, but not any fat, because again, we don't want insulation. We want them to be able to breathe. Okay? All right? The scrotal raphe is sort of a remnant of where the vagina may have, the vaginal opening would have been if this patient had developed into a female instead. So the raphe is just a line. If you look at the undersurface, it's just line that sort of extends from the corona, which is the corona of the glans is this posterior ridge, and the glans is the entire head of the penis, but that raphe extends from the corona all the way down to the perineum, okay? The scrotum itself, there are numerous layers. I'm not going to ask you to go internal, external. I'm not going to ask you what is the middle and second layer of the scrotum, because it's not super important, but it is important they just understand that there are multiple things that make up the scrotal tissue. It's not just skin and that's it, okay? But as far as asking you where's the fascia in between this and that, it's not a good bang for your buck as far as like your clinical relevance, okay? So, but there are a couple, looking at it, there are a lot of very important structures in there. So clearly the skin. Now dardos, this is the one I told you And as you can see, this sort of is the muscle that extends throughout the scrotal tissue itself, throughout the actual scrotum. That's the muscle, again, that brings the scrotum skin up and physically brings the testicles up with it, all right? But the muscle that actually maneuvers the testicles themselves individually up and down is the cremaster muscle, okay? The cremaster muscle. So it's this one. The cremaster is a part of this structure right here. What is this structure, you guys? We haven't got to it yet. Does anybody know, though? The spermatic cord. The spermatic epididymis is in the spermatic cord, but the entire structure together, covered by the cremaster muscle, is the spermatic cord. Okay? So, yes, the cremaster is technically part of the scrotum, as it is, superiorly, as the spermatic cord attaches to the testicles in the superior poles, right? But the dartos goes around the entire thing. Okay? The spermatic fascia is not super important. Tunica vaginalis, this becomes very important because if this is not properly developed, or improperly developed is a better way to say, the patient can be at a higher risk for testicular torsion, okay? So improperly fixated tunica vaginalis gives the patient what's called a bell clapper deformity, and I'll show you that in a minute, and it predisposes the testicle to turn, and that's testicular torsion. Okay, and we'll talk about that here in just a few minutes. But it's divided into two separate compartments, right? And that is important. Why is that important, do you think? Exactly, so they can't twist on each other. One, testicular torsion is a turning of the testicle on itself. If we didn't have that septum, that separation, they could literally turn on each other. And the other things, why that's important, not just that it hurts. What's in the spermatic cord? I didn't tell you guys yet, but arteries, veins, right? So when we turn and spin them on it, if they spun up together, what would happen? Ischemia. And then what does that lead to? Necrosis, right? So it's important for them to have that separation so they don't turn on each other. And then we'll discuss what happens when they turn on themselves here in just a minute, okay? Does that make sense to everybody? Okay. And again, we talked about regulation of temperature and what these individual muscles do, right? The dartos, think of it as that big blanket muscle that's in the entire scrotum, and the cremaster's in each individual. So there's two cremaster muscles, one dartos muscle. That's the easier way to think about it, perhaps. One cremaster on each spermatic cord. So left side, right side, they can ascend and descend the actual testicles, not the scrotum itself. Okay? Cremaster also has a very critical reflex, all right? And most of the time what you're checking this for is to see if there is testicular torsion. You basically just literally rub the inside of the thigh, inside of the patient's thigh. And doing that creates a skeletal reflex, and should ascend the testicle. The cremaster should fire, and the testicle should ascend, okay? If that's absent, it typically means one, there's some sort of neurological deficit, or two, more critically probably, is that there is torsion of the affected side. What does that mean? I'll show you. Let me show you. Has anybody ever discussed this with you? Because I don't want to just leave random words on here. In this course, like everybody knows what has talked about caudate equina before. The horse's mane, the horse's tail, excuse me. All right, okay. So caudate equina syndrome, absent cremaster muscle, which is based on the level of the neurologic deficit. Caudate equina syndrome's out there, you guys. You'll see it. I've seen it. So be careful of it. That's why when you get to ortho and you start to see the red flags of low back pain, it's very critical that you assess for those and document those as positive or negative. Because if you miss them, it's going to be bad. Anyway, enough about that. So, literally just rub the inside, stroke the inside gently of the patient's thigh on the side of the ipsilateral testicle that you're, does everybody know what I mean when I say ipsilateral? Same side. Ipsilateral testicle that you're assessing. If it fires, it means if the cremaster contracts and the testicle goes up, that's a positive cremaster reflex, and that's good. Okay? If it's negative, that's bad. Means one of those things that we had in that little list. Now, what is testicular torsion? It's exactly what I said. It's a turning of the testicle on itself, and that basically twists up the individual somatic cord, okay? And why would the cremasteric reflex be absent if that's twisted up? Exactly, it has nowhere to contract, right? So you test for contraction and ascension of the testicle, ascent of the testicle. It's absent because the muscle is twisted up, so when it contracts, it doesn't have anywhere to go. So that's why it's already up. It'll be high riding as it is. You should appreciate visibly a high riding testicle, meaning one is elevated higher than the other. But then when you do that reflex, the muscle has nowhere to go, so it doesn't move. Does that make sense to everybody? Okay. You guys are going to talk about that a lot, so don't worry. All right. Testes, singular. Testes. 1, 2, 3. Testicles, plural. Okay. Paired oval glands, egg-shaped. There is such a thing as an orchiometer. It's this crazy looking set of Mardi Gras beads that's different sizes of eggs, and that measures the size of testicular size. Pediatricians have them a lot because measurement of testicular size is usually something that comes along at and post puberty, if there's delayed puberty effects or anything like that. So there is such a thing as an orchiometer. Okay. So they develop. This is again why we do a check as a well child or well baby initial check to make sure we have descended testicles, because they are supposed to descend during gestational development. If they haven't, it doesn't necessarily mean it's pathologic, right? It doesn't necessarily mean, because we can wait a little bit when the child is born for the descent of the testes, but if you get to about 18 months and it hasn't descended, we're going to bring it back down, if not sooner, okay? So it's really important because, again, they're not developed in the scrotal sac, they're developed in the pelvic cavity, and then they descend before birth, all right? So again, keep that in mind because it is important when you're evaluating infants. Tunica vaginalis is a covering tunic. What is a tunic? It's a covering, right? Tunica vaginalis is part of the scrotum, right? It's on the outside of the testicle, so it's one of those, it's the inner layer of one thing, the outer layer of another thing, okay? If it doesn't close properly, it can be a communication that can allow fluid in there. That's called a hydrocele. We'll talk about that in just a second. But again, see, it forms from the peritoneum, right, during descent of the testes. And so if the layers don't fuse and we have a space between a visceral layer and a parietal layer, that is where fluid can accumulate, just like we talked about in a normal process, like when there's a visceral parietal pleura. We have fluid in the middle. We're supposed to have fluid in the middle. But in this case, we're not. So it's supposed to fuse, all right? High riding tunica vaginalis. So what this means, for testicular torsion, the tunica vaginalis is supposed to close and only sort of be here normally, which gives the testicle fixed in the scrotum sort of an upright lie, right, an upright position. If it's able to maneuver too much, meaning it has the ability to move and turn not only here, but like sort of turn this way, right? More of a horizontal lie. Okay, it's called a bell clapper deformity. You guys know what a bell clapper looks like? Imagine the Liberty Bell that has a hammer on the inside and clang the inside of the bell. So that's what it looks like. Like a bell clapper sort of is in this configuration and then moves from side to side to ring the bell. So that's called a bell clapper deformity, because instead of a vertical lie, the testicle is lying in more horizontal fashion. And what that allows is too much freedom of movement, essentially, right? We want the testicles to be able to move a little bit on themselves, right? One actually does hang lower than the other so they don't cling into each other. That is normal, okay? But too much movement, just like with anything else, like we talked about the heart, way back in round 1, right? The heart can move in the pericardial cavity, but we don't want it moving too much or else it'll just spin around and you'll die, right? This thing, we don't want them moving too much. So if we have that much freedom of movement, it gives the scrotum, just normal movement and activity, it gives the testicle the opportunity to sort of turn on itself and create torsion. Okay, does that make sense to everybody? So here, like just look right here, a much more limited. Imagine the red line is its freedom of movement. It can move a little bit side to side, up and down, front and back, but it's relatively stable in its position. If this can move, let me get rid of this. One second. Come on, stupid. If this has this much freedom of movement instead of the other side, you see that not only can the testicle move, but the inferior part of the spermatic heart, the inferior part of the spermatic cord can also move, and so that gives it an opportunity to turn on itself. Does that make sense? Does that make more sense now? Yeah? Okay. Sorry, I had to Control-Alt-Delete there for a second. All right. So torsion, what this means, and you will get this, again, emergency medicine, urology, but if you ever have a patient who has testicular torsion, most testicles turn inward. So imagine I'm standing at the foot of my patient's bed, my patient's laying down, the feet are right here, most turn inward like that, okay? So what they say is, prophylactically, if you're going to, in a field expedient manner, if you need to get this untoured because maybe you're far away from definitive surgical care or whatever, turn like you're opening a book, right? If I'm opening a book like that, you turn the testicles. The easiest other way is turn them toward the patient legs, okay? And see, what you're looking for is relief of pain and sort of descent of that testicle back into its normal place within the scrotal sac. Truth, and then I always tell it, like, don't do both of them, right? If you only have one side, don't twist the other one. But if you twist it the wrong way and the patient's like, no, then go the other way. Because most do. I say that tongue in cheek, but the truth about it is you're not going to make it worse. I mean, you might make it worse. There might be a limited blood flow. But if you turn it the wrong way, just try to turn it the other way. You're doing your best, right? Because what are you really trying to do? Are you trying to alleviate the patient's pain? No, kind of. What are you really trying to do? Save the testicle. Save that limb, right? You guys are familiar with evacuation categories, life, limb, I said this is tissue loss, all right? So this is something that we need to intervene for, especially if we can't get to surgical capability. Because ultimately what this patient needs is what's called a surgical fixation. And what they'll do is they'll take that tunica vaginalis and they'll sew it to the inferior scrotal wall on both sides to literally sew the testicle in place so that it can't move anymore. Because if the patient has it once, they have a very high predilection to have it again, and the next time they might not be so lucky as to be able to get it treated, right? So they take care of both sides. And then just another little thing for you for Gee Whiz, if you are successful at detorsion, opening the book, good for you, but that's not the end of it. Because if that patient moves the wrong way, sneezes, coughs, it's going to spin right back up. Right? So the definitive care is to get that patient to surgery. All right? Anyway, enough about that. Otherwise, this happens. Does that look good to you? About 4 hours-ish is your window, right? Which seems a long time. Anybody ever seen or had torsion? Anybody want to share? Yeah, saw it?
My son actually had it about 3 months before 7 years.
How old?
He was 6.
6? What was he doing? Was he doing anything or was he just sleeping? Because sometimes kids can get it when they're just sleeping, actually.
Yeah, he does have autism, so he jumps on the trampoline and all that stuff. But honestly, he just told us that his private was hurting, so we looked and it was like swollen.
Yeah.
And so we went to the hospital and then.
Did he get surgery?
He actually didn't. So they ran him up to the OR, and about like 2 hours later, they came down and like, oh, we actually didn't go in. It fixed itself, and if it happens again before he's a teenager, they'll go in and tack it. Is what they said.
Tack it, yeah, sew it, yeah.
Yeah, and but they're like, no, but his scrotum looks like a bruise for days, like.
Yeah, interesting choice not to fix it.
Yeah.
Because like, why would you want the patient to go through that again? It's a simple surgery, just pop it open. Right. Anyway, all right, well, good. I had one, the first one I ever saw, one of the soldiers was having a number 2, and he was straining. right? And so they come in the aid station like this, because so that nerve, the genital femoral nerves, the testicular nerve, everything is angry. Imagine, for those of you who have testicles, being kicked in them, only over and over again, nonstop. Like, it doesn't go away, right? It is a visceral type of pain that irritates the abdominal cavity too. It can cause severe nausea. So a lot of your patients will also be vomiting, having severe nausea if they're not vomiting, and just be extremely uncomfortable. So luckily we were in Garrison, so we just sent him to Tripler, and he got surgery, but it can happen in the most innocuous situations, like you wouldn't even think. But so I did ask him, like, did you wipe, or did you just kind of walk over here? But it's anyway, I think I've gone off on a tangent here, but hydrocele. So this is what I was talking about. So there's multiple different kinds of seal, C-E-L-E, that we're going to talk about for the scrotum and the scrotal contents. Hydrocele is where there's too much of a communication in that tunica vaginalis, a patent processus vaginalis, they call it. So the tunica vaginalis is the covering here that we discussed. The processus vaginalis should be what should close, right? So there's a little bit of fluid left in the tunica vaginalis, the part that's in and around the testicle in the scrotum. The process that communicates with the peritoneum should close. Processus vaginalis should be non-patent. You know what that means when I say non-patent? Closed, non-communicating, okay? If it remains open and it is communicating, what does that mean? That means peritoneal fluid can start to accumulate at abnormal levels in the scrotal cavity and around the testicle. And what that patient will complain of is a large swollen testicle, typically on one side. But what happens, why they have, it's not a pathologic process per se, because ultimately that peritoneal fluid will attain the same temperature as the scrotal content, so it doesn't necessarily have the same infertility risks that we talked about with like varicocele. Do you guys remember? I think we talked about that. Maybe we didn't. If we didn't, we'll talk about it later. Anyway, it doesn't really, it's more of a benign process, just to put it that way. But the patient will complain of heaviness and pain on that side, because literally the weight of that fluid pulls down and irritates the nerve in the scrotal, in the spermatic cord, and so the patient just complains of a nagging irritation on that side. And a lot of times we can treat it conservatively with rest, ice, scrotal support, meaning tight undergarments, so that tug on the spermatic cord is relieved. But oftentimes, especially if it's a communicating one like that, it's going to come back, be recurring, so they just go in and they close that processus vaginalis and solve the problem. Transillumination, have you guys talked about that at all in clinical skills? A good toolkit for you, a good thing to have in your toolkit is called transillumination. And basically all you do is, if you have a scrotal mass, try to shine a light through it. And if a light does transilluminate through it like it does here, you see it glows through and you can see on both sides. That tends to mean it's a clear fluid, a serous fluid, and so it's relatively benign. That's a hallmark of a hydrocele. If it doesn't shine through, if it's more obscured, if it doesn't shine through at all, that means it's either more milky or milky fluid, something more like a varicocele, hematocele, spermatocele, something like that, or it's a solid mass. So transillumination, positivity, like the ability to transilluminate, is a reassuring sign. Did you?
Yeah, would you go in and drain this?
No. No. That's a great question, and it's a good question because it seems like it makes sense to do it, but ultimately, especially if you have a communicating hydrocele, it's just going to fill back up. And so you're just going to be sticking a needle in a place where the guy probably doesn't want a needle to do really no good. You know what I mean? And again, like I said, I know I've gone on my static fluid. This may be the exception to the rule, because in general, I have never heard of a hydrocele becoming infected. So it's not something you have to treat ultimately, urgently, you know what I mean? But yeah, no, don't stick needles in it. If it's a reactive hydrocele because of some sort of inflammatory process, that will resorb and go away on its own. If it is a communicating, like this one is, then it's just gonna keep filling back up. So there's really no reason to put the patient through that when you can just send them to get the you're gonna treat the problem, not the symptom of the problem, right? Make sense? Right, the problem is communication, the symptom is the fluid, you're gonna treat the problem, close the communication, right? Okay. Alright. Tunica albuginea. It's basically, what does albuginea mean? It means basically it's a white covering, and that's exactly what it is. It's the outside of the testicle that sort of gives it its shape, holds its shape. It is white in color, you'll see it. There also is a tunica albuginea that covers the cavernous bodies in the penis itself, that helps maintain the rigidity of an erection when those fill with blood. And now, this also, tunica albuginea, I'll show this on the next slide, it actually helps create sort of septae in between the lobules, individual lobules. Each lobule has a seminiferous tubule. I'll show, again, we're getting to that, I'm kind of getting ahead, but that's what that means. And then the lobules in each functional unit, right? So lobules are like, the lobules and the seminiferous tubules are like the nephrons, right? If you cut a testicle in half, you just see stuff. You don't see the seminiferous tubules. When they get larger, like into the efferent ducts and the vas deferens, then you can see them physically. But if you're just when you see a sagittal section of testicle, you're not going to see like the individual lobules or even the septa or the seminiferous tubules. They're just microscopic in nature. Okay. So if I'm looking at this, the tunica vaginalis is on the outside of the scrotum, right? So this part, the albuginea is this white covering here, like all of this stuff. Okay. And as you can see, it creates these sort of individual sections. There's septae that create the lobules, which become sort of the individual functional unit of the testicle itself. Okay? And just while we're on this, I'll show you because we're going to be going into the ducts in just a little bit. But this spaghetti right here, this guy, that's the seminiferous tubule, right? And then we go into a straight tubule. This is the reed testes. This sort of like meshwork right here is called the reed testes. And then we have efferent ducts. What does efferent mean? Going away from, right? Efferent ducts into the epididymal ducts, and then ultimately this. Let me erase that. And we're going to go through all this again. I just want to show you because it's right here on this. This is a nice picture. This entire thing, which as you can see is a distinct structure separate from the testicle itself. This is our epididymis. This big whole thing right here, and the epididymis ultimately goes into the vas deferens, which enters the spermatic cord. Okay? So we'll go through that again. We have a whole section on the ducts. I just want to show you because this is a nice picture. So, okay? Talking about, it's only, 3 minutes? Why don't you guys take 10 minutes and then, I started late, didn't I? What time is it? I got 3 more minutes. Never mind, don't go anywhere. Sorry. I'm gonna get through this. We're gonna be done early today too, so don't worry. But let me tell you another thing for this block, especially the male anatomy side. Everything starts with S. Okay? We're going to talk about sustentacular cells, Sertoli cells, spermatogenesis, spermatogonia, spermatids, spermiation, primary spermatogenesis. Everything sounds the same. You're going to have to get it straight. It's presented straight, but just make sure you keep the processes and the cells and the individual things straight. And I will do my best as we're going on to make sure that I highlight what the difference is between each are to keep it together. Okay? So, spermatogenic cells in the seminiferous tubules actually make the sperm, okay? Sertoli cells, this is the eponymous name, but let me ask you this. What is sustentacular? Does that sound like a similar homonym word to sustenance? Exactly. The other name for Sertoli cells is nurse cells. They sort of feed and prepare the spermatid for maturation. All right, so the spermatogenic cells, that's easy. They actually become and make the sperm cells themselves. The sustentacular cells, Sertoli cells, support spermatogenesis. And the easiest way for this one, because the other ones we're going to talk about are Leydig cells, that starts with an L. Sertoli sustentacular, I'll be with spermatogenesis, sperm, okay? So you keep that one straight if we're talking about the two differentiation of two major types of cells in the testicle. All right? So, spermatogonia, this is where we start, right? They have a primordial germ cell, so we're starting, we're going to ultimately end up with a sperm cell. They start out as spermatogonia, okay? They don't. What spermatogonia, what this process is right here, again, I'm not going to talk too much fetal development, but essentially what this process is, where the arrow I drew is, it's like pre-spermatogenesis. You don't really start creating sperm as mature sperm cells until around puberty, okay? So, they have the tools. You could harvest sperm from a child, but it doesn't necessarily, it has to mature first. So, real spermatogenesis begins around puberty, alright? So, sustentacular cells, the Sertoli cells, I'll show you here in a minute, but we'll talk about their function other than spermatogenesis. But again, if you think of sustenance or nurse cells, that's what they essentially do. They take care of the young spermatogonia until they mature and break away, essentially. Alright? You guys know we're talking about the blood-brain barrier? Okay? We also have those same tight junctions in the testicle. We don't want stuff that doesn't belong there getting in to affect spermatogenesis, right? So physiologically, anatomically, the male body sees a sperm cell is equally as important as a neuron, okay? So there you go. All right? Produces fluid, right? So we have some fluid. This is not seminal fluid, this is not ejaculate, this is fluid that allows the passage of these cells within the tubules themselves as they progress from the initial tubules all the way into the vas deferens, okay? And then supports mitosis and meiosis. You guys have talked about that, those processes in Anatomy and Physiology 1. I assume, right? Mitosis and meiosis, cellular division. All right, so we're just going to, we're going to briefly touch on them, not go too deep into that process. Okay. Spermiogenesis, again, look, a different word. It doesn't say spermatogenesis, it says spermiogenesis, so it's a whole different word. Okay. Essentially, spermatogenesis, for some reason, is the whole overarching process. Spermiogenesis is this part that takes place within and around, not within, but around the sustentacular cells as they mature, they begin to mature, all right? Antigen binding protein, because again, one of the main things that supports the sustentacular cells and the overall process of spermatogenesis is testosterone. So we do need testosterone for this production to function. Okay, so we need antigen binding protein, so we keep a supply of that testosterone within the testicles themselves, all right? And does anybody have a guess? Does anybody know what anti-Mullerian hormone is? Anybody? All right, so anti-Mullerian hormone during gestational growth, essentially this prevents the development of female sex organs in utero, right? So anti-Mullerian hormone makes sure that as the testes develop, it promotes testicular development and not vice versa, okay? Now, sustentacular cells, Sertoli, nurse cells, okay? Now we're going to talk about Leydig cells. And these guys produce testosterone. So we have talked about these in the past in our endo block briefly, okay? But the Leydig cells do deal with testosterone. And that's the way, like I said, if we're bucketing these when you guys are studying, the sustentacular cells deal with all this stuff. S, sperm, spermatogenesis, spermiogenesis. Leydig cells deal with testosterone, okay? So you can keep them separate in your mind that way. Does that make sense? Yeah? Okay. So if you're looking at this, and this is a pretty good picture as well, here we have our Sertoli cell, and you see it's that sort of greenish thing in the middle with all those immature sperm cells. like just nursing around it, like you think about it that way, talk about nurse cells. So they're getting substances from the sustentacular cell that help them to mature into ultimately a sperm cell, okay? And then you have the Leydig cells out here running around just making testosterone, okay? Just to keep those separate, and that's good, that's right there, that's, if we're there together right now, that's good, all right? Anybody, have any questions so far? All right. And then there's the actual picture. Okay, so spermatogenesis, the whole process, we start with spermatogonia, okay? And they have a 2n number of chromosomes, right? Because they're not a sex cell yet, they're not mature, they're not a mature sex cell yet, not a mature gamete. So, we have testosterone from the Leydig cells, and they differentiate into primary spermatocytes. I told you this is all gonna sound similar for a little bit, okay? Primary spermatocytes, they replicate and they become secondary spermatocytes. I have a roll-up of all this, by the way, so just stick with me if it seems like I'm going a little fast. So secondary spermatocytes, now they're haploid. What does that mean? 1N, right? So they have half chromosomes. They're ready to mature into spermatocytes, but not yet, okay? At meiosis II, we have 4 new things called spermatids. All right, so we started with spermatogonium, it's split, primary spermatocyte split, now we have 4 N haploid spermatids, okay? All right, and this is the easiest way to look at it, right here. So this lines up with what's going on next to it. And it really does make it easier, just look at it in this one roll-up, I think, okay? So we stopped about right here, we're at meiosis II, we have spermatids, okay? Still got steps to go. Maturation of sperm cells not complete yet. All right, so we still have a couple of steps. Spermiogenesis, final stage of spermatogenesis, okay? We have the development from the spermatids into a sperm, okay? 1 spermatid, so we have how many spermatids? 4. So we have 4 sperm cells from 1 spermatogonium, okay? And we'll talk about we have a cell, I'm not gonna, if it seems like I'm skipping steps, it's because we have this on a slide, so I'm gonna show you this, like the individual portions of the sperm cell here in just a little bit. It's easier if you're seeing the picture versus just trying to describe the words, okay? After this slide, we'll take our quick break and then we'll come back and we'll be done pretty quickly after that, all right? So again, spermiation, this is when the nursing is done at the Sertoli cell, okay? So we have our sperm cells. They're still not mature, but they are now sperm cells with the look, everybody can imagine what a sperm cells look like. They break away, sort of imagine they swim away or break away from the sustentacular cell, okay? And then they are allowed to move into the ducts, okay? So, forget that I said they swim away because they really don't. They just sort of float away, all right? So just think right now of the flagellum being inactive, all right? Okay, and we'll go into what a sperm cells look like in a minute, and we only have like 10, 15 slides left, so you guys go take a break. I know there's too many S words right now, and I'll see you in a little bit.
Make sure I eat this straight up. I'm trying to say the word.
I told you, yeah.
Sperm. I'm gonna say it wrong. Spermatogenesis. It's just that final stage. Spermatogenesis.
Spermiation. spermio is the last one, so it's on 2 different slides, just so you understand. This is and the other one,
So the overarching, just to make the overarching schematic is, the final stage is spermio.
spermio. I know. I mean, it makes, yeah, and you know, it's not, once you sit down and like actually look at it, it doesn't make sense. Yeah, just write them in order and just like make them.
Just say Genesis.
Whatever keeps, whatever keeps it straight, go for it. Yeah. Are you guys in the last part of everything except A&P I?
Mine broke down. We're in block 4 and 5 now.
Okay.
One we're in 7. It's just biopsy in your lab or last.
Yeah, we got 3. There we go. Last in the lab next week, and then that's in the next one. So it's another good setup. You guys are all
Starting to, so I've been a long period. We didn't have a test Monday, Friday. Now last month it's like Monday, Friday. Starting to pick up again.
Yeah. Yeah.
Like literally the exact thing.
Sophomore semester, pretty chill. Classes get harder, but classes also, I mean, I'm not gonna fool myself into thinking you guys came here and listen to me talk about things. You guys came here to learn about like medicine, right? So you really start doing some of that. So even though it comes with like maybe more difficult material, it becomes like more engaging, I guess. You know what I mean? As far as like, all right, yeah, this is what I'm, I want to see patients and all this stuff, right? Which is why the junior semester is like simultaneously like the hardest. Those one of those like it's like all yes. So
How much do you retain semester to semester? It's not really like something sticking out. Like, oh yeah, like, I was able to remember, even after phase 1, like, oh yeah, I remembered 80% of what I learned. Where were you kind of at semester to semester?
it'd be hard to quantify it. Yeah, I mean, you remember. I'll tell you this. You remember more than you can. You will. All of it. And that is, I mean, that's not just me speaking of personal experience. There are some times where like seniors are saying, you guys are going to you take that as a grain of salt. In general, you remember more than you think you do. Especially at Manifest Life. Where you just like, somebody asks you a question and spit something out before you even think about it. It's like a movie old school. Yeah. Where you just like, then he shot out. That was perfect. And then like, when you go to, you say the pants, a lot of people say the pants is way easier. I thought so, honestly. Even though it's like super stressful. And like, again, that's just not just me, like feedback you can have, just come back and like bowling and shit. It's like, yeah, I was super worried.
I passed on just setting stuff up.
Just random stuff in your brain against your will, and you can't tell you how to just send your email and feel it. You know, I mean, you're done. Nope. It's not hard. I mean, you'd have to do it 50.
That curve of like where it's
So that's the biggest thing that's the scariest thing about when you knowing your own limitations. Three who think they know everything and don't want to ask questions and still use solution which is the best they're people who understand their own limitations. There are
Yeah, but we already took the 6 2.
Alright. Is that, we good? Is that enough time? Thank you. You guys hear me? I'm gonna start. Alright, I think that's enough. We're almost done, just keep it together for a little bit, alright? The internal workings, this stuff is the most difficult part of the male anatomy side. And again, it's only really because it all sounds the same, so just, if you keep a process map in your head, or if you make one that just sort of outlines which of these processes as they go along, like that chart, like this chart is the easiest one to, I think, to build off of, to understand what cell is where, and how many chromosomes it has. And again, just putting together that spermiation is the last part, where the actual cell is now, it's a sperm and it floats away from the nurse cell, okay? Now, we're talking about a sperm cell. It's still, again, ultimately, you guys, so I don't have to say this 5 different times, ultimately the sperm cell doesn't become fully mature and capacitated until it is in the female reproductive system and comes near an egg. Alright, so that is when final maturation and capacitation happens, and I'll explain that in just a minute. But the head of the sperm cell is called the acrosome, that's where all the genetic material is, alright? It's sort of shaped, with not being tongue-in-cheek, it's sort of shaped for what it has to accomplish. It has to penetrate the outer casing, if you will, of the egg, and so it's sort of shaped in a pointed fashion with that flagella, that really strong flagella, to really burrow its way in. And that's ultimately what happens when we talk about fertilization, okay? And that is where all the genetic material is in the head and the acrosome of the sperm cell. We'll talk about what's called the acrosomal reaction here in just a minute. The tail, it's divided into these pieces. Let me go on this one because it's easier to see it. The mid piece here is where all the mitochondria is. And what do the mitochondria do? Powerhouse of the cell. It's really rich with mitochondria because again, it has to swim and it has to not only swim, but it also then has to ultimately create enough force to penetrate the outer casing of the egg, of the oocyte for fertilization. So it needs a lot of that mitochondria, and then the tail and the flagellum, and then for some reason this is called the end piece. I don't know why. I don't know why this is separate. It doesn't make any sense to me, but just so you know it is. Alright? Maturation of sperm, so going farther into the maturation process, right? 1 to 2 weeks after spermiation. So after spermiation, what does that mean? Tell me what spermiation is again? The release of the cell from the nurse cell, right? The release of the sperm cell from the nurse cell, alright? It makes its way through the seminiferous tubules, which are the initial part in that lobule. Then it has to go through straight the efferent ducts, all right? And as it's making its way 1 to 2 weeks there, and to get to the efferent ducts into the epididymis, it takes about 1 to 2 weeks for that to happen, all right? In the epididymis, once it gets there, remember the epididymis is that comma-shaped thing, which is distinct from the testicle itself that sits on the posterior lateral surface of the testicle. So you have the testicle, on the back side is the epididymis, all right? And if you're palpating testicles, you can palpate a distinct separation between the epididymis and the testicle itself. Anyway, that's what the epididymis is, and that's where it is. Once it gets there, it spends about another month. These are all give or take times, all right? To undergo further maturation, all right? Maturation, excuse me. And so we add from the from the epididymis, some fluid, some epididymal fluid, and then decapacitation, all right? And I know we don't know what the acrosomal reaction is yet, but just suffice it to say right now, it is the reaction that occurs that allows the sperm to become active and to penetrate the egg. So that doesn't need to happen now. We don't want that to happen yet prematurely. We don't want that reaction to happen before it meets an egg, or else it's just a dead cell, right? The whole point of this cell is to make it to an egg, physiologically, okay? So a decapacitation basically think of it as an off switch, it turns it off, okay? The sperm can't fertilize an egg, it turns it off so it doesn't turn on until it's near an egg, alright? Now, capacitation, everybody know what penultimate means? It's a great word to use. Huh? Yeah, right? So, it is almost the final step, right? But what happens for capacitation is once it's in the female reproductive tract, in the oviduct, it basically undergoes the second to last step to turn the switch on. So decapacitation turns it off, capacitation is it's on now, it's ready to be able to fertilize an egg. That's like a dumb way to say it, but does that make sense to everybody? The difference between those two, okay? Like, capacitation, think of it as it's capable now of fertilizing an egg. You might think about it that way, alright? And so, we have destabilization of the acrosomal membrane. What does that mean? That means it's getting ready to be able to penetrate the egg and then release its genetic material for fertilization, okay? And the tail actually sort of increases its ability, it increases in strength, alright? So it's making sort of like a whip rotation like movement to be able to actually burrow, okay? To burrow in and think of it as like a motor, like the motor on a motorboat, spinning around like that to propel the acrosome into the egg, okay? Alright? And this is when it happens. I know we don't know what the ampulla of the fallopian tube is, that's the most likely and most common site for fertilization. So essentially, the acrosomal reaction, the final step happens when it comes in contact. Alright? Let me show you. It has sperm make contact with the egg, right? So the point of the acrosome after the capacitation has happened, so now the proteins are rearranged to make it burrow into the egg surface. Alright? It makes its way through the zona pellucida, which let's just say it's the exterior surface of the egg right now, that's perfectly fine. And as it burrows in, it releases its genetic material to intermix and fertilize the egg, okay? So again, listen to me, you don't need to memorize everything on this picture. This is a visualization, okay? And basically what this is a visualization. Now we have the sperm is in physical contact with the egg, the acrosomal reaction happens, that's the final step, and that allows it to burrow in and release its genetic material into the egg. That is sufficient. Does that make sense to everybody? Yes? Okay. All right. Any questions? Literally that whole spermatogenesis process is the most difficult stuff. I know it comes across confusing when I'm up here saying it and then stumbling and stuff like that, but if you just put it together when you look at it, it doesn't take that long to unpack it in your brain, I promise. And if it does, if it's confusing, let me know and I'll put it together in a different way that hopefully makes it easier for you. Which is, once you look at it a couple times, by the time test day comes around, I don't think you'll have that much difficulty with that stuff. But that is the hardest stuff as far as the male anatomy is concerned, okay? So, hormonal control of testes themselves, all right? Gonadotropin releasing hormone, remember all these? Anybody? No? Anybody remember where gonadotropin releasing hormone comes from? Huh? Hypothalamus. Yep. All right. And then the anterior pituitary gives us LH and FSH, which are gonadotropes. Okay. That helps stimulate. LH stimulates the Leydig cells for testosterone. That is very convenient because both luteinizing and Leydig start with an L, so they work on each other to produce testosterone. Okay. FSH, again, conveniently has an S in it, and it stimulates spermatogenesis. All right. I needed this stuff when I was in endo. Endo was the one topic that used to mess me up a lot. So if you can remember it in a less dumb way than putting letters that sound the same together, then good for you. I can't. So this is why I'm telling you this stuff. All right. So Leydig cells, luteinizing hormone gives you testosterone. FSH gives you spermatogenesis, okay? Testosterone, of course, all right, so once the Leydig cells make the testosterone, again, we saw some of it gets bound up with androgen binding protein to keep it in the testicular tissue so that it can facilitate and complete the process of spermatogenesis, all right? Peripheral conversion of testosterone estradiol, we have talked about this does not necessarily have anything to do with male anatomy, but we have talked about that, especially in a significant amount of adipose tissue, specifically in a large pannus. Anterior belly fat really converts a lot of testosterone to estradiol, which makes it hard for overweight patients to lose weight. Testosterone, androgen binding protein, albumin, and then free testosterone. We've already talked about these fractions earlier on, okay? So in this case, it's one of those ones that has a specific binding protein, and albumin is just the generic one, but most of our testosterone floats around on androgen binding protein, okay? And why does it need a binding protein or albumin? You guys remember? What kind of hormone is testosterone? Lipid soluble, right? So what does it need to float around in the blood with? Something to carry it around, essentially, a carrier protein. To render it temporarily water soluble so it can float around, right? Exactly, good job. Alright, and this right here, again, we're not necessarily focusing too much on androgenic effects because I'm not talking about puberty or development. So give this a look, but don't really worry about it too much as far as like trying to memorize all of this stuff. I'm telling you that now because this isn't really anatomy and physiology as so much as it is the effects of hormones, and you'll learn this a lot more when you get to pediatrics and when you get to endocrinology, okay? Fair enough? You're just picking up what I'm putting down here? Okay. Ducts. Okay? So if you're going inside to out, so like we're working our way from the seminiferous tubules, from the lobules to the epididymis and then out to the vas deferens. So that's the direction that these go. I'll show you that again in this picture, okay? But straight tubules come directly after the seminiferous tubules, and they feed into the retestes. That's sort of that webbing, all right, immediately before the efferent ducts, okay? And the straight tubules are easiest because they come directly off of the lobules and they're just straight tubes. I mean, that they're really named for exactly what they look like. I'm not sure if you can see that red, but the straight tubules are pointing where that one goes, okay? And then again, the retestes, this part right here, is sort of this network that all of the straight tubules feed into. And then after that, we have efferent ducts that go into the epididymis, okay? Efferent ducts. Now looking at the structure of the epididymis itself, I'm going to switch over to this little guy right here so I don't draw too much on this. But this is the head of the epididymis on the top portion, and you're looking sideways. So this is anterior, this is posterior, okay? So the head of the epididymis, like I said, it's a common shape that sits sort of on the outside. It's not fully separate from the testicle. It is attached, of course, but when you're palpating it, you can separate the head and the tail. You can feel distinct portions of the epididymis that are separate from the testicle itself, right? So head, tail, and after the efferent ducts, we go into the epididymis ducts, like the ductus epididymis. They all sort of flow from here, from the retestes, and as they're going out, efferent, they become one thing, which is just one big tubule through the epididymis, and this big thing right here becomes the ductus deferens, otherwise known as the vas deferens. So one more time for the cheap seats, okay? We start at the seminiferous tubules, then we go to the straight tubules, to the retestes, to the efferent ducts, to the ductus epididymis, to the vas deferens, okay? I know that's not gonna stick the first time you hear it, but it's not that hard to put together, okay? seminiferous tubule, step 1, vas deferens, final step. All right? So again, ductus epididymis, after those efferent ducts become one tube, that's what that is, as it's flowing from the head to the tail of the epididymis. In other words, as it's going from superior to inferior, then it curves around and becomes the ductus deferens. Okay? Got all of this. We got more sperm maturation. Remember I said that the epididymis, the sperm will sit here for approximately a month or so. I mean, those are very approximate times, but there is more maturation to be done after it leaves the seminiferous tubules. So that's a site of that, okay? And it also does smooth muscle within the ductus deferens, helps propel the sperm cells into the urethra when during ejaculation, okay? We'll talk about that in a minute. You may have heard of epididymitis before, what is the itis? Inflammation, right? Inflammation in this case, infection. Generally, there are non-infectious causes of epididymitis, but by and large, the most common cause of epididymitis are sexually transmitted infections, okay? There are also, if you get to an older population, and by older, we generally mean, unfortunately, 35 and older, which is a weird delineation, but that's the urological definition. And so, I'm telling you. And so, then you start to get in some more enteric organisms, all right? Especially when you have patients, and let's just talk about legitimate, like when you start to develop prostatic problems. Let's say in your 50s or 60s, you have that sort of prostatic obstruction. You can get infection in the epididymis that has more to do with enteric organisms, so more like an E. coli infection. So there are multiple different ways to diagnose this and to elicit what's going on with your patient. But ultimately, either way, whatever happens to get in there, the epididymis becomes swollen and tender and inflamed and infected. It causes a lot of pain for your patient. It'll come along with a swollen, hot, red, tender testicle, and usually the scrotal skin is red and warm as well. There may be some urethral discharge, and then you just give them the appropriate antibiotics, which of course we're not going to discuss in here, but that is epididymitis. Yeah?
Is there any referred pain with this?
Referred pain, I mean, there's not necessarily anything that was referred, but these patients a lot of times will have abdominal pain as well. Yeah. They might have some pain in the perineum, especially if they have associated prostatic difficulties, but nothing that refers typically. Yeah. Somehow, I mean, what this is commonly clinically confused with, oddly enough, is testicular torsion. It doesn't really look, smell, or act like testicular torsion, so it's basically just because you have a hot red swollen testicle that obfuscates the physical exam a little bit. Right, but not really any referred pain per se. Okay, the ductus deferens, the vas deferens, well known as the subject of the vasectomy. Okay, so when you undergo a vasectomy, you cut the vas deferens, which is the tube that delivers sperm into the ejaculatory ducts. So it removes the pathway, but essentially it is a portion of the spermatic cord. It is housed within the spermatic cord, surrounded of course by that cremaster muscle we talked about. When you're palpating a vas deferens, when you're palpating a spermatic cord, what it feels like is, you know the old big pens where you can take the ink out of the middle, and that ink, or like a small coffee stirrer, it has that about an approximate rigidity and an approximate size. And so you can actually palpate this distinct sort of firmness in the spermatic cord, and that comes in handy if you're trying to do a vasectomy because you need to know that you're cutting the right thing. Okay? But in the spermatic cord, loops up over the urethra, comes back down the posterior side of the bladder. At that point, there are also seminal vesicles, which we'll discuss later, that inject other fluids to become semen. Nutritious fluids, zinc, like things that the sperm need to survive the journey. Okay? So vas deferens, if you're looking at, let me go back here real fast and I'll come back to that one. So from the tail of the epididymis, up in the pelvic cavity, around the ureter, and down right here. And let me get rid of that and show you something else real fast, and we'll get to it in real life in a minute. This is a seminal vesicle, and this ultimately where it dumps into is called the ejaculatory duct, where it meets the urethra. Okay? I'm going back. The terminal portion is technically called the ampulla of the vas deferens. It's not really that important. It just comes into a larger cavity where it dumps into the ejaculatory duct. But it's basically a passageway, right? It does provide some nutrition. It does provide some propulsion, but ultimately it's a passageway. It's a tube. Okay. The spermatic cord. Now, any questions about the ducts, the duct work? No? Okay. Spermatic cord, vas deferens, testicular artery, pampiniform plexus of veins, some lymphs and nerves, of course. Anybody know what I mean when I say a plexus of veins? Yeah, that's a spider web. Like a spider web, a pattern of it. I'll show you these. Alright? But that's the venous drainage from the testicle. Alright, so those are the different distinct things. Now, oftentimes you can sort of make out, in a non-pathologic state, you're not going to be able to really distinctly tell between the veins, the arteries, the lymph, the nerve, but you can feel the epididymis, right? It should be the most distinctly palpable structure in the spermatic cord, right? The pampiniform plexus, right, why this is called out on its own is because when it becomes engorged, when it becomes varicose, a varicosity, like varicose veins we talked about in the past, it becomes what's known as a varicocele. Anybody heard of varicocele before? Okay, so it's an abnormality of the spermatic cord itself. Okay, and I'm going to go forward and back. This is the pampiniform plexus, right? You see that sort of spider webbing of the veins there, right? Okay, let me go back. Why it's important, and then I'm going to give you a question on your urology exam in your senior semester right now. Okay, the right side, the right testicular veins drain directly into the vena cava. Okay. The left side have a little bit more of a tortuosity. They have to go into the renal vein and then they have to take the turn into the vena cava, right? But the right side is this tiny little artery that dumps into the tiny little vein that dumps into the second biggest vein, right? So there should be no reason for obstruction to that flow, right? On the left side, we give it a little bit more. There's some turns it has to take, so some of that flow may be obstructed just by atherosclerosis, something like that. So it's less concerning if a patient has a left-sided varicocele. Okay? And let me explain the varicocele again. Imagine whatever it is. There's a blockage somewhere here, an obstruction to flow essentially, that's causing an engorgement of these veins downstream. So what you feel is what's called like a bag of worms, is what they call it. Like when you're palpating the spermatic cord, it actually feels like worms because of the engorgement of those blood vessels. Now, again, if you're on the right side, there should be nothing obstructing this pathway. If you're on the left side, maybe, okay, we give it a little bit less concern. But on the right side, if we have some kind of obstruction from that tiny little vein dumping into that huge vein, we're concerned with something as far as pressing on it, like some kind of retroperitoneal pathology. So if you have a patient with an isolated right-sided varicocele, you need to get a CT scan of their belly, see what's going on in there. All right? I used to give that question. I gave that question every single time. I never changed it. It was the same question. I told every single senior class, this question is going to be on here. You're going to walk right by it, and then you're going to get it. A couple of you are going to get it wrong, and there's never 100%. And in the little blue box information, I put, I told you this was going to be on here, right? So it's on there, all right? And it's important, all right? It's important to know that. Not necessarily now, but when you're in urology, it's definitely important to know that. But does the anatomy, what we need to talk about right now, does the anatomy make sense about why on the right side it would be more concerning than on the left. Because you have a tiny vessel dumping into a huge one. If something's impeding that flow, it means something might be there that's not supposed to be there. Not all the time. It doesn't mean it's a 1-for-1 correlation, but it's enough clinical suspicion that you have to rule it out, and then you can just say, well, you just have you just have something going on your right side. It's not a big deal. Okay, does that make sense? Yeah? All right. And then again, that's what it looks like clinically. You can usually appreciate them visibly. Another way to have your patient, if you want to call out a varicocele that may not be clinically obvious, is have them Valsalva, have them bear down. That intra-abdominal pressure might help push some of the blood down, and then you might be able to actually appreciate visibly or tactilely, palpably see or feel a varicocele that may be small. If the patient's complaining of like testicular pain, you can't identify why they have testicular pain. Anyway, okay? And the varicocele, again, it means it's more common on the left. It's more common bilaterally, but if you have bilateral, or especially if you have isolated right side, you need to get that CT scan, okay? And then ultimately, if it causes the patient so much discomfort, you can ligate those vessels and the patient will be just fine. All right, but enough about that. Does that make sense? The anatomy portion more so than anything else. Does that make sense? Okay. All right. Almost finished. For the ejaculatory ducts, this is a good place to stop after the urethra because we've already discussed the urethra before, and we'll finish up. We'll be done. Okay. So you have here the vas deferens coming up behind here. This is posterior, right? So we're looking at the posterior, the back side of the bladder. These are our ureters, right? Coming down from the kidneys, entering the bladder. The vas deferens sort of hooks over top of that down into this widened portion, which is that ampulla, and it dumps into the ejaculatory duct, okay? Let me get rid of this ink because it's too much. I know it's too much. So then we have these sort of paired organs right here on the posterior surface of the bladder. These are seminal vesicles, and they basically produce seminal fluid, all right? And then they join into the they dump into the ejaculatory duct as well, and then they meet up at the prostatic urethra because the prostate also produces some fluid that's in semen as well. Okay? Does that make sense? So it's a fairly easy structure. So again, when you're identifying, I'll show you this on a sagittal section that we have, but the ejaculatory duct, it precedes the urethra. So if you're looking, you find the bladder neck, then you know that you're at the prostatic urethra. Posterior to that, in tiny little space, is the ejaculatory duct, okay? We've talked about the male urethra before, and the prostatic urethra, this part that goes through the prostate. The membranous is the shortest section, right by the urogenital diaphragm, and then the entire length of the penis is the spongy urethra that goes through the corpus spongiosum, which we'll talk about in a little bit, okay? And that's the urethra. That is all for today. Thank you for your time and attention. Any questions? All right, I'll see you guys tomorrow bright and early, I guess, 8 o'clock. See you.